So I'm coming back to the story how I met Francesca because I think she's doing something magnificent for dentistry, something that many times for many, many years we tried to achieve and we couldn't get it. We couldn't break that wall of connection between restorative dentistry, top level, high end protocols in prosthodontics versus rational occlusion in the way that we think. And I think Francesca was able to have that totally control the reputation, the beautiful dentistry that she practiced, and allows the world to finally get the respect to start listening about an occlusion that breaks paradigms. So the background from Francesca, she's a top level prosthodontics, doing prosthodontics in the regular way for many years. But he has one plus that starts changing the dynamics of her life and the dynamics of the perception that the dental community start accepting it. The first one is she started training with Professor Pascal Magnier in adhesion. And I think that created the first adhesion, the first bonding connection with this reputation to have an amazing dentistry. So Francesca is the kind of dentist that every radicular root tip has the potential to make an amazing 20 floor building because it's all about adhesion. And also she's a well defender to don't prep teeth, to preserve the structural of the enamel and to keep the conditions of the bonding in the best way as an important to preserve the vitality and the successful of the restoration. That's what I call top end dentistry. And after this, she get inspired. I don't know how. That is what she's gonna tell us. And she get totally out of the box. So I was seeing in a quintessence ceramic symposium, and I see this doctor showing cases with worse dentition breakage that we have in patients with pain. Patients with no teeth, 2 millimeters, crazy eruption compensations, totally bruxism, everything that I don't think we even get to have those cases here. And then I seen that she's open vertical dimensions dramatically, but the most important is she never even mentioned how she take the bites, but you see that the mandibles, they wasn't in a posterior position, wasn't not in a habitual central relation. And you can see physiologic decompensation, and she was building on that. So when she finished the lecture, I just grab her for the hand and I walk with her and I say, Francesca, maybe you don't know me, I'm Javier Vasquez. I believe in occlusion, and what you just show, you blow my mind. And from there, we start this relation. So this is what I want to share with you guys, how she participates in the process of occlusion. She is not a doctor that she treats patients based in pain. So the collection of data that she does is different, but it has too much more that we as a physician dentist, the one that we are in the other side, we need to know. We need to know how magnificent, magnify dentistry, to how to preserve adhesion, how to preserve and stop being mutilating cases by aggressive restoration. So now I'm not going to talk more. I let you, Hamid and Francesca,
Well,
tell us about that story.
first of all, thank you so much, Francesca, for making the time to join us and share some of your wonderful work with us and knowledge. I want to assure you that we don't have a specific mold, as Javier was saying, for the practitioners that we asked to join us. We just really chose people that we thought they're doing extraordinary dentistry and can add to the discussion. So without any further ado, please go ahead and let us.
Tell us a little bit about that. How would you start? Because it's easy to do good dentistry. Everybody is oriented to do smile design, digital planning. So we're taking advantage of those tools today to facilitate predictability into the cases. Tell us about a little bit about that importance in adhesion that I think, at least in the community that we are around, we see, and mostly here in America, is a lot of lack of isolation, for instance, when we do bonding. And how here eventually we're a little more aggressive in preparations, mostly because maybe we don't implement that much about the adhesive. So what I wanted to tell us is how that is so important, and how was that connection for you into function, and how one day you decide, you know what, this doesn't make sense, this is what I'm seeing, and this is how we're going to start doing it. Because after that you build that, I will tell the story that happens when you were taking the courses with me in Dijon, and how blown away I am in the way that you take your bites that is so close to the bites that we take. So let's go just by steps. But I don't hear you,
No,
Francesca.
no,
That's
no,
it.
no, you can
Now,
hear
yeah.
me. Can
Now,
you?
yes, yeah.
Yes, now.
The story is that I was trained as a prosthodontic because I was wearing braces all my life. I really wanted to become an orthodontist, but I love the laboratory of the pros, imagine. So I was always doing laboratory stuff, and I went to pros. But when I decided to go back to Europe, I was coming to Europe as an ITI implant scholar. Can you
Oh,
believe?
wow.
I was totally into another direction, was placing implant and do classic subtractive prosthodontics. But I knew I was not so happy. It was not good in my hands. I was enough good, but nothing special. And I felt that there should be something different. So my completely blow up mind moment was with Pascal Magne, because I was out of the boat for 2 months in Geneva. I was supposed to place implant. They never saw me in the surgical department. I never went there, but instead I just aspirated to Pascal Magne, and I was asking questions like, tubula, dentin bonding. I didn't know nothing, and he was so kind to answer my question, because I was really level 0 of adhesion. I was bonding with zinc phosphate.
Oh.
So imagine. And when he left, because after 18 years, he decided, of course, to go to Los Angeles. I was there, and from the day he left, the second day, I went and I was the dentist that had to treat Pascal Magne patient, the dentist that had to take care of a Pascal Magne student at the University of Geneva. Everything happened with adhesion and veneers that was not working at the University of Geneva. They were asking me, and everybody was asking me that in French, that I was not speaking one word. So I think for 4 months, I was only studied the book of Pascal, emailed to Pascal and said, Pascal, help me. But I felt that I finally found the tools, because I love my prosthodontic training for the laboratory, the wax up. I love it, the global vision. But what I didn't like was these irreversible tools, because they don't allow you to make mistake. That is the beauty of additive prosthodontic. Every time I decide to treat the patient in these not invasive, no minimal invasive, not invasive, 0. I always have in my mind, if it doesn't work, I remove everything. So this was my first initial going into the function, because if I was treating this eroded patient, yes, I was reconstructing their mouth. But after that, I start to get other patients. They were looking at me and they say, do you have another solution? I'm like, let's try. So that's what it happened. That I was just to say, well, with this protocol, it's called the 3-step, I can really decide for each patient how to build what I call a try-in, a test drive, all additive that the patient should wear. It's perfectly bonded, even on top of existing restoration. And that is for me what was my eye opening, because I stopped to anesthetize my patient while I was doing this occlusal classic stabilization. I had people telling me, but I don't like this. I don't like that, because they were totally aware, and they were also sitting on an upright position, never like this, because it was at the end of the session. And after, I remember this girl that came, I was doing the classic occlusal adjustment, and that was the end of the day. And she asked me these powerful tools and say, can you give me a gum? I just finished to bond the veneers, and it was just a very little overjet, overlap, nothing. So she was ready to go home, and she started to chew. My staff already left. I was by myself. It took me more than 1 hour with the gum to make her comfortable, because the way she was chewing was completely unexpected to me. And with the regulation, the classic going from in, out, nothing applied to her. And so that's why I start to give this chewing gum to my patient to check for the capacity of my restoration to fit, because we as a dentist are always want that this restoration lasts long time. But I realized that not only I was finding conflict and so removing interference, but I was start to say, hey, but if I have to give you a new way of walking, can I just see how you walk in the first place? So I start to give the gum to everybody, because it's just a chewing gum, an iPhone, something that everybody can do Monday. And there it blew my mind, because I start to see that one was chewing one way, one was chewing the other way. And I start to ask while I was doing the video to people. And so if you ask me the question, who teach me the neonatology that I do? My patient, because I learned to observe things that I was not observing when I was in my classical training, because I was reading literature, how the mouth should work, but I was not really looking at people working. And so at the end, I learned that there is a variability, and I learned the limit of me as a dentist, but I learned the huge potential that we can have, not only to avoid to create a damage. And so from the additive, adhesive, I was already into the preservation, maximum preservation. But also I say, you know what? If I put this increase of vertical, and the first thing the patient tells me is, I can breathe. I say, well, I have a goosebump every time I think about this patient. Mm-hmm. So that's, I have a medical degree before a dental degree. So that's blow my mind, because I say, wow, they always think about the dentist as a narrow person looking at to fix holes and to remove infection. And now I can make these people better. So there I start to do killing my ego, because that's why this year at the symposium, I'm not invited. You and I knows, because I was there with killing my ego for the aesthetic, and things look fantastic because they function fantastic, but they are not interested in movement. They are interested in the final symmetric one way fit all. And we are people that don't fit in that system, because we do in the name of the patient. So for me, first the patient, after my human experimentation, my research, and after that my publication and blah, blah. But nowadays I don't publish anymore, because my case are less glamour, because I am less over treatment and less pushing the smile of everybody for every age. No, now the second topic, the hot topic is, yes, but which is the physiology for that specific patient? So we have to aim, is he already in a physiological chewing pattern? Do we need, can we modify? And can this modification will last in time with the aging of the patient. So this is bringing so much power, but also the concept, I am really aware that I cannot do miracle, but I can avoid to do damage.
Yeah, that's no.
Sounds
So
great.
so far, what I'm seeing is, and the main point is, because you relate more with that restorative doctor, that maybe they even know that canine guides or articulator is not enough, but they don't want to dig in information anymore. So I think you that point of connection about a restorative doctor, that they consider that the rational part of what we do, they connected with signs and symptoms, that connected with our full body as an entire unit, is overwhelming. What I like from you first is that you open-minded. You were so open-minded that I'm nobody for to have you in my course, and you when I took my
I have
courses
to
in
come back.
Dijon.
To come back.
But that was beautiful that you get exposed to really the rational thinking we do, and then you were able to connect into that. And we have magnificent conversations about it, because with all these cases that you will show us in the marathon, that the people is going to realize how dramatic are the enamel augmentation that you do in these cases, how conservative they are, and how they have amazing results. That's like the connection point that I want to make for this. I want the people to be being scared to modify the occlusions into the patient and just get out of the traditional manipulation, because that's the main point. So I'm going to tell you a story that is a true story with Francesca and I. When she was taking level 2 in France in Dijon with me, we were talking how we take neuromuscular bites, how we take cranial bites, utilizing the TENS and everything. So we practice in groups. So she was practicing with another doctor. We get the chance to take bites for Francesca, but also Francesca brought her own bite. And it shows me how is the process that she take the bite registration into the patients. It's something that many other physiologic doctors take care in consideration. But the point that I want to do here is how important it is to start thinking out of the box. She combines the walk into the patient, into the office, with cotton rolls, and in the way that she made the technique, because she really pay attention. And this is the most important part, to pay attention to the patient and connect, to try to find out what is the common pattern, to get that information to say, hey, this bite need to be around this. So long story short is, she took the patient, the bite in her weight to the partner that she was working into the case, and then I took my bite. We get the 2-bite registration, we measure with calipers, we make lines for the vertical, for the AP shaft, and I can tell you the bites were almost identical. So it's a bite that is just based in full observation, no biometrics, no transelectrical stimulation, just trying to catch the beauty of the body. Of course, you need to be a good observer to be able to see that. And then just develop the skills to try to get it together. But the beautiful point is that now she can see that she was going in a great direction, and since there she's more inspired to know a little more about that rational part, that is to understand how it connects. So I'll let you talk a little bit on that, and then we will
No,
continue.
what I say is that when people say gnatology, and myself, we were like, oh, no, I just do aesthetic. I want to tell you, everybody, nobody does only aesthetic. So we don't have the possibility to skip function. And that's why I like to test each patient in a way that I can modify, but I go not with the many tools that Monday another dentist cannot use, because I want to go back, like I always bother people around me. I want that so many people go back to see neonatology. But this, if you do with the patient helping you, because the patient will tell exactly which is the uncomfortable part of what we have created in the teeth. But to do so, you need the patient that is not anesthetized. And many times my patient tells me, hey, but my dentist, my previous dentist just told me, go home and get adapted. I don't let this happen. So for me, the feedback of the patient is the most important thing. Is a haute couture, like a dress. So I work with composite, but it's not that I stay in composite, but I don't move to ceramic if I am not sure that I provide the patient with the best fit for that mouth. And while I'm doing that, I also start to look at which population I'm looking at. And as you already say, I don't have any problem to refer a patient to somebody that I think is better than me. So for instance, I refer to Valentin Precup patients. And I just want to tell you, because we need to give protocol to people that listen. So when a patient comes to my office, it's not only because they have a worn down dentition. So I am looking at people that are just uncomfortable with their bite. So what I look and I say, where is the margin for me of action? Does it have a good posterior support? Because if it does not have a good posterior support, let's give that posterior support, because for me is a must. I am tired to see mock-up of 6 anterior teeth in people that don't even have the premolar. So this is set to failure, because if you don't even have premolar and you give a chewing gum to these people, you will see that they chew on the front teeth. So those front teeth, they are meant to have the incisal edge flat, so they can be transformed in an occlusal surface. And we are not talking about overloading the TMJ. We are talking about that the dentists nowadays are so concentrated to the survival of the restoration. Instead, I'm more attached to the patient, attached to my restoration. So it's a different deal that I do with these people. So posterior support. So if I see that the posterior support is lacking, I don't start with other people in my team. I'm a dentist. I make sure that this person has a good posterior support. After that, I want to see, does he have any garage car discrepancy? And you see that with this madness that we have created, with this rejuvenation of the smile, we see people that I define explosive in the way they are aging with this wall syndrome. So it means that there is a functional conflict in the dynamic when they chew, when they speak. And with the gum, you can see immediately that there is no way that you can only repair 6 teeth. You do a mock-up, give a gum, and you know that the patient will bang. So that I take care of that. How do I take care of this wall? I have to go and open the garage by a test drive, everything additive. I open up and see the feedback of the patient. While I'm open up, I can even see, do I have to open in the same direction? Because we always have, like Roccabado, see this one vision. I think about the mandible 3-dimensionally. So I see that many of my mandible don't need to be open like this, boom. They need to be open and change the torque, because the torque is something that
you do think about the joint.
I do, but I don't do instrumentation that I cannot do on the desert island. So that's why I love.
Yeah, but you say that you're carrying the iPhone today. You say so.
Correct.
You're carrying an iPhone and a chew gum.
I'm just making light of the previous comment.
Document, and that's why our goal is. Okay, so let me go to the phase. I am in phase 3. Let me say what are the phase, because each dentist should understand in which phase is. Phase 1 dentist is the one that receive a patient and the incisal edge are broken and just look at them. And it will most probably redo this incisal edge without thinking even at the level of the teeth, if there is something else that they can do. Phase 2 dentist was me with the 3-step that I was saying, oh, if there is no space, let me increase the vertical dimension to reconstruct without cutting this remaining tooth structure. Phase 3, it's me today. I not only open, but after that, my goal today is to take asymmetrical structure, that because I treat an adult population, I cannot change so much what has been developed in years of malfunction, of unilateral function, for example. But my goal is to do the way that they open up their motion, they start to move, and they move in a symmetrical way, bilateral way of chewing. And some people will say, oh, Francesca, you give too much space to chewing. Yes, you know why? Why? We are not moving the mouth. We are not eating, we are not breathing, we are totally hypotrophic. And so now I want to share with the world, I don't know if there is a word, listen to me, but I want to share something that is something that everybody's making fun of me. You have to know that I think there are 2 ways of chewing. One is the good way, that is horizontal, but if you go more wider, you become a ruminant. And we want to be omnivore. But there is a cycling. And this cycling, imagine how it's good for the TMJ, because has this motion that alternate on one side and the other side. And you see this mouth that they breathe. The gingiva is fantastic, because my way of observing the gingiva nowadays is totally different. My restoration is good. The gingiva are happy and healthy. If I don't do well, that would be the first thermometer of my mistake. Anyway, so this type of chewing with the freedom of moving, it's is opposite to people, and this is us, because unfortunately myself, I am like this. Vertical chewer, open and close, the chopping people. Mm-hmm. So if you see kids are all vertical chewer, narrow, they don't develop centrifugal force, they are collapsing, everything is closing down, the tongue is claustrophobic, the lips are tight, they are clencher. And so what do? We have to train. This is important tools, cost thousands of euros. So every day I put this one in my mouth. Is a caoutchouc from a baby toy, so I hope it's not so plastic, it's a little bit less. So I go in this one and I reproduce the chewing pattern that I cannot do because I don't have food that will allow me to really do exercise, and I don't have the teeth position in this possibility of chewing. Because unfortunately, I have been treated in an orthodontics beauty, but it didn't work. Nobody at the end of my ortho give me a chewing gum and say, you are beautiful, but you don't dance. So that's what I wish for the orthodontics and for the prosthodontics, to check that at the end, this beauty that we give, this alignment that we give, is good. Because you know how my condyle are completely broken. I went and do an MRI, but do I need an MRI? No, I can already see. And so every day I check, I do this motion that for me is the correct motion in moving this articulation also. And you know what, even more crazy, and I know that people will get after me, like they went after me when I say, let's stop touching teeth. These little things is stimulated my periodontal tissue. The way we stop doing, because nowadays the only people that are really stimulating are the grinder, but the clencher are not doing correctly. We have all these fiber aligned in a correct way, and when you see people vertical, they just slam their teeth one against the other, and the perio is really stressed. When you have this way of chewing, you enter and you are so nice to carry out by the teeth. And that's why I'm really looking forward to hear Milieu. They will talk about Marcel Legal, that I want really to thank, because these were my intuition with my patient, that see them chewing. And Milieu met me and said, hey, but you know, there is this guy that spoke exactly like you. And I say, thank God, because being the first one is not good, because nobody give you credit. So,
but no. Actually, it's very interesting that you brought. I mean, yesterday we had a excellent discussion with Dr. Roccabato, and the very first thing he said, why is everybody looking at the vertical and opening? He said, we need to learn and check the excursive movement first. So I'm actually hearing a lot of resonance in what you're saying.
But Hamid, seriously, I have to say, if you take, so let's go at G-test, you take a gum that is not the hard one, and smaller you make it, better you could see. Why? Because I don't want food. In my private practice, I cannot have food that how much can swallow the patient is dirty. This one can be reusable. I check. Right. So normally I take half of them, and I ask the patient put in the mouth. And when they place it, they always place in the side that they prefer. And I let them chew. And after that, I start to check how they chew, because you could see. But people don't know how to do this G-test, because, for instance, they place like a retraction cheek. Instead, you see, I went on the right. The right is my preferred. So they start to chew, and you let them go and forget that they have a gum. And you will see not only conflict, but unfortunately, what Marcel Legal has shown me, the importance of the first molar to direct the jaw. And how many times the first molar is not present, absent, is not with the correct compensatory curve, Spey, Wilson. So get the gum.
Yeah, but that also is related with the position where the mandible is. So I think you make an amazing point. Function is vital. Is something else in particular that you're going to teach us about the G-test?
See.
Okay, so, we want to know that, because we need to come back some structural questions, just because now we know.
But let's say we combine. So let's say that I receive a patient and I see that I cannot do anything from the teeth point of view, because teeth is my, teeth is my place. So if I see a patient and I see that I have perfect teeth, I could do ortho, but even ortho can mess up a patient, because not many, unfortunately, orthodontics are following the final goal as improved function. I don't want.
Yeah, they're retruding.
So if I see this patient, like the patient that I sent to Valentine, she's a young individual. She has a perfect teeth, posterior support, teeth that could be even aligned correctly. She chew not correctly. The mandible seems okay, because with my cotton walk, the programmation in the first visit, I look at her. She is this posture like this. Send back. Send to somebody that will take care of a posture first. So that's my way of diagnosis, which is my 70% that I will take it and I will work at the tooth level. There is a 30% where I don't see a dental problem. But where I see a dental problem, we can do miracle. And if we reactivate the function of the patient, not only by chewing, but even exercise, because our food does not allow us to really do motion. I mean, how many of us are walking 2 hours a day? My knee don't move because I'm always sitting. So I'm supposed to do on the trial and do exercise to compensate. But if I was going and walk, be in my gardener does not need to go in the gym. We need, because we don't do exercise. So the
So let's wrap a few concepts around it. Some people is asking and saying that who cares about physiology, that the patient wants aesthetics, and technically, I think you're the best person to answer this because I can see that you taking care about physiology because you're aware that the patient has breathing better. Second one, because you deprogramming the patient and you making an analysis of the posture as you describe, the way that you walk. So of course you care. So it's people that cares about physiology. We know the effects in that. And then of course you're protecting the case, but also you're rebuilding the case in a functional manner. So it's just a
So
point that I
let me
want to create
answer
to the
the
community. It's
question
value
to,
for what we
no,
do.
let me answer the question to the patient wants aesthetic. Yes, but how many parents have kids that wants Nutella? Patient wants aesthetic. My patient wants aesthetic too, but I am there with the little trick to show them that they cannot have Nutella. So I already show, if you take the patient come and say, I want to repair only the 6th teeth, and you see that there is no space that you can redo it without creating a locking of this jaw, just take a little flowable, place on the lateral, there's many times in this dynamic conflict, polymerize without bonding, and give a gum. And my patient that wants only the 6, they start to chew on the other side, and they start to bang on the little repair provisional. And at the end, they say, hey, I hate that. I say, okay, go and break it. And they go like this, they chomp it off, they look at me and say, okay, I know, I cannot have only that.
That's
That
a
is
great
a
trick.
desert island trick. So
No, so the point is, yes, you're creating value for the patients. You're creating value. You have, first of all, I think it's many conditions to be able to do physiological dentistry. And doesn't necessarily mean that you need to work with physical therapy, chiropractors, via physical therapy, or have instrumentation. Technically, you need to have an open mind to know that it's many dynamic compensations that need to be achieved. We cannot test a car sitting in the garage, and you cannot take the car just trying to go in and out 1 millimeter. You need to expose it to a totally dynamic range of motion. So based on all the information that you gave us, and Hamid, we need to kind of go fast to
forward.
this.
Yeah, we need to go.
But let's try to simplify the question. So
Okay.
Francesca, don't go to extended in the answers, but we really want that you give us an opinion in the order that we ask in the questions. Based on what you say, we know that you're not using complex instrumentation, but we consider the G-test, the current rolls, and all that physiologic techniques. I mean, this is this.
semiotic. We have to start to go back and observe, touch,
Yes,
hear
I'm
the patient.
100%. That's why
100% accept. No,
you need to listen the interview for Valentine Pre-Cup. That is the beauty interview that it shows that even that we have all the technology, we're learning to be good diagnosticians. And that's
correct.
why in 2 years we have no use instrumentation in the courses because we're teaching the people how to diagnostic without tools.
Well, this
Okay.
is an important point. I think instruments help us with giving us data. The diagnosis still has to be done by the physician, and if you're astute enough, observing the patient is still the best.
And listen to the patient, because many of them tell them the story. But we need patient not anesthetized if we touch, if we talk about function.
The occlusion, of course. Okay, so let's go to the first question. And again, short questions. What is the occlusion? Camille, go ahead.
All right. So the first question is that what is the occlusion to you, and who was your influence? I know your influence already was
Legal.
No, my patient. After that, I found people that tells me, but you do like Legal. Okay. Hey, these things look like planas. But I have people like, right now, I have my little group of research, Confaloni, Reali, Corti, that you most probably don't know, where we sit, I see their patient, and we do discussion, but with the semiotic. So I want to go and see more muscle. We are going into the tongue, in the sleep apnea, but I'm not the person that is there after 20 years. But you will see me for sure in the future, I will go back to do simplified protocol, because if your colleagues cannot use on Monday, this is not a real
I
message.
totally agree. It's diagnostician. So we will see when we're gonna show, and we've been talking about how we're gonna build up the 4 steps together. So we try to simplify, because honestly, part of what we teach is use diagnostic. So second question.
So which factors do you consider prior to stabilization? I guess if you give us, I think it's your posterior support for you.
No, because
right?
if you see the way I do the 3-step, for me is I do both of them. The posterior support, the anterior little touch while they are swallowing. It's a back and forward. Cioè, at the end, my occlusion is built in more steps with the patient comfort guiding me, with the swallowing for the static, and with this cotton walk to just make the brain forget about occlusal interference. But from there, my patient do their own adjustment on these, what I call therapeutic bite. That's why I love the 3-step that is bonded 24 hours. I need the feedback of somebody that chew, that swallow all day long. I don't want a removable bite, because removable bite, it's not a full picture.
True. All right. I guess the third question is which type of information diagnostic records do you collect?
It depends in which patient I have. In the first visit, I want to make a simple diagnosis how this mandible is wrongly positioned because of the teeth. I'm not talking about the neck. I'm not talking about the muscle contraction. I just want to do a quick deprogrammation that is just placing 2 cotton in between the teeth, making the patient move faster. And I realized that in many cases, I already can see this mandible relax. So this is a very little way even to communicate with the patient, because the patient must understand that there is not a perfect contact once the brain is not there to intercept pre-contact. It's still at the dental level. And after that, my tools is my 3-step, because it's completed in 2 weeks. I have a patient with the new project, a test drive, and it goes with the gum, with the feedback of the patient. They walk, they stand up, they do whatever, and it's just we have. It's haute couture.
So let's say that you use
cannot
tools.
do on the mannequin, on the articulator. Is my starting point, the articulator.
Is dynamics.
The patient is my articulator.
Yeah.
And that's it. When people say, I don't want to do occlusal adjustment, my lab technician should give me everything. I say, maybe
good luck.
Maybe in static could be okay. But in dynamic, forget about the articulator.
Yeah, totally. So then we can say, yeah, definitely you getting information, and the record that you collecting are oriented to the dental part. That is totally valid. Okay, perfect. Fantastic. Now, next question.
Next question is, which instrumentation do you currently use to collect data, which is basically your...
the gum.
The gum. And see, totally, I don't have instrumentation, but I have a vision that I have 2 muscle type of, so for me, I agree with Roccabado. Muscle win. In my mind, I have this idea that I'm only a dentist that try sometimes to go against the nature of the patient. And I have 2 dysfunctional nature. The explosive one, they are guided more by a protrusive attitude while they are aging. With the big tongue, even when they speak, they go forward with the S sound, and they will end up edge to edge. And we, because they, for aesthetic reason, we try to give with additive a little bit less to slow down this process. The second group are the implosive. So those people, they are really aging with the mandible that goes back and the maxilla, they ate it up. And so these people are much more difficult to, in my opinion, to treat. And those are always, I have the osteopath, but I need to have first my idea. So I need first to say how much of the dental I can fix. And after that, they go with the osteopath. The osteopath gives me a record on the iPhone. My patient come back because it's not in my office, and I hear all the if it's getting better, if it's getting worse. So all of my patients have an osteopath, but the message is I'm still doing without it, because I need to be sure that my part of the job is correct. And you can really, first of all, don't do damage. That's my goal, is that patient that come in my office, they walk away with a better or equal function.
You don't do no harm.
No.
I think you partially answered the next question, which is
yes, it
you
is.
use an interdisciplinary approach, and sometimes you do. So sometimes you are working with an osteopath. So let's go to question number 6. If you have to establish a sequence of treatment, what would be that order? I guess that would be your 3-step. You do have a sequence.
I have a sequence where in the 3-step you give to the patient the aesthetic. But in the first visit is a diagnosis, because I need to understand which conflict these teeth are involved. I have a static conflict, I have dynamic conflict, and there is a little piece of this conflict that I don't have a clue. So what happened is, more I become better in diagnosis, more my final diagnosis become a sign. I explain myself. If your diagnosis is incisal edge break, if you become better in diagnosis, incisal edge damage is a sign, it's not a diagnosis anymore. So right now, my final diagnosis is muscle problem that will give explosion or implosion. Maybe if I enter more in the phase where you guys are, that muscle activated in that specific way will have another reason to be, and it will not be my final diagnosis, will be another sign, and I have to work at the other level.
Interesting. The important thing I think we wanted from that, also I failed to mention, was about the desired vertical dimension. Now, do you choose that based on, I'm going to go to the next question, which is facial aesthetics. Do you use, or do you choose your vertical dimension based on, let's say, incisal display, gingival display, in other words, facial aesthetics?
No, I want to play the story of the garage. So who are the people that come to us to talk about the garage door broken? The explosive.
Yeah.
So if you look at the explosive, the way I interpret them is that their muscle will bring them to age improtrusive. So my way is to try to go against their aging by increasing the vertical and making again the garage door repair. The mistake that I don't want to do any longer is with these people to make a door that is too close, because what you see with time is that the increase of vertical that I provide to this patient will go back, because they are also affected by clenching. So it's a battle that as a dentist, I cannot really win, because I am at the point of my diagnosis that I don't know why they are explosive patients. So that's where I want to investigate why they have this tongue. Maybe Roccabado will help me with the muscle underneath the jaw. They will push forward. I don't know. But that's my intelligent way, is that when I do mock-up in this explosive patient, the garage is always shorter and flare, because it has to be out of the way while the patient will lose vertical dimension, and that will close the garage in the anterior part.
Fantastic.
So I try never to give mock-up to this type of population that will make them look 20 younger. I want first to give them a easier aesthetic to carry in 20 years. So you will see that my cases are becoming less glamour, because not everybody can afford the 12 millimeter central incisor.
Correct.
Correct. I'm gonna try to modify next question, and I know you do not do any kind of surgical.
We can make it use as an opinion because she's additive in everything. So
correct. So considering the fact that you do not do surgeries, and we're keeping that in mind, and you do not, at least for now, time being, you do not really look at the joint itself, theoretically so speaking. If you knew you could actually heal or help or remodel condylar joints by adding these biological factors like PRGF and PRP, do you think that would be a good idea?
I think as long as I, as a dentist, recreate the function, if you put something even more, I don't have a problem with that. My problem is that if we think that only placing that and have the people not to move. So for me, function win over. If I walk with my knee and I do exercise and I do aqua gym, maybe I don't need the hyaluronic acid inside, but maybe I am an old patient that needs the aqua gym and the hyaluronic acid. So why not? But it's easier to start with function than to find a surgeon that will do those injections.
Absolutely. I think we had consensus on that also with Dr. Roccabato yesterday. And he thought a protective bite, in other words, taking the compression off the joint, which is kind of what you're doing, is critical and should be the first step.
Basically, when I do the no arm, in my opinion, the mandible, they should be centered from a muscle point of view, should be all the movement that make this mandible become equal, forward, and large. I like it. Everything that makes my mandible be inside, retruded, and like this, I don't like it, because
that is clear physiology. That's beautiful.
Simplify, but like that, because we have a claustrophobic tongue. Every ortho, they will make this one smaller. No. We need to move this retruded mandible.
Thank you. We could not say that any louder, to be honest with you. But this is exactly what this is all about. Finding those, even though you think we may not be doing the same thing, Francesca, when you talk, you sound exactly like us, and everything you say makes complete sense to us. So this is what we were looking for those common grounds, and finding what it is that you're doing, and we're interested because yes, what we do, it does scare people, and they're like, oh, it's too complicated, and how you do it, it's so simple, and it's
but what I need about you guys is that to give a validation to simplify method. So what I mean is that if you are in Africa, you have this nurse, they take the baby and they do cholera, malaria, like this. They are fantastic in diagnosis. If you take the same baby and you take to an Italian hospital, a Swiss hospital, they will take hundreds of exams before making a diagnosis. So I need you guys to give validation to this simplicity, this easy way based on observation, based on tools. So at the end, people that want to have more sophisticated will do the sophisticated, but people that want to start with the G-test, with the true fit, with the just making a film of the patient, they feel that they're not just doing a lower quality, they are doing even a lot, because to rehabilitate the patient.
Yeah, but it's a really important point in what you're saying, and because it's a huge difference in population in dentists exposed to this situation. So it's going to be the people that they don't get that involved deep in like the dentistry that we do, but it's the other group that they want to keep it simple and physiologic as you are, But it's a group that they just want to know, they don't want to learn anything, and they dismiss everything just because it shows complexity and more work. And this is the people that I think it doesn't let the profession to grow. There is the
Well,
people
to
that,
each his own.
I
To each
mean,
his own. I don't think we need to, the great thing about our profession is that you can practice it in all different levels and do what you like and go after your passion. And there is no judgment about anybody.
But
The
if you
only
do
stipulation.
additive, Hamid, you
What's that?
have this luxury to do mistake.
yeah, as he
That is
said, is
huge. And if
Correct.
you
No,
have this
absolutely.
luxury, you do things out of the box. Because I have people that were supposed to do maxillofacial surgery, and I just end up with the 4 onlays, and I got the compliment of his osteopath that is in a clinic in Paris that work with the people that got the maxillofacial surgery, and they were not so well like my patient. So we need both of them.
No, absolutely. The only stipulation that I see, Francesca, from your methodology is that I don't think everybody is as astute and detailed as you are. And the way your eyes have trained by just experience to pick up these things.
But
So
that's why we do protocol. That's why we do protocol. That's why I always, I'm a Italian, and that is my creativity, but I'm totally Swiss. So for everything from the 3-step to the 8 passage of the control visit. So it's all in protocol. That's why I'm looking forward with Javier that he developed this protocol for the phase 4, because people like me, instead of spending 20 years to develop, would like people like him or like you to give direction. That Monday, we, even though we don't have this view sophisticated, we can do a desert island. On a desert island, I can do a G-test at all my patients. I can do a cotton work to all my patients, and I can have a 70%
yeah,
good result.
that's definitely.
Sounds great.
So that's beautiful. And that's the point that we were trying to do, is that I think the minimal requirement is that at least we have the information. And I think that's the reason that we're doing it here. You don't need to be an expert. You need to be able to identify, know that is going on, give value to that, and just find your team and refer. Exactly. You don't need to treat it all. You need to be able to identify and be able to refer. Um, it's a fact that the question number 10, Francesca already answered that.
Yes.
That is, now for you, this is going to go a little, because your academic background. The question number 10 is not objective question, but you consider that eventually in the universities or in general, we're going to be able to have a little this view, the more holistic approach, just that you're really involved in academics.
I wish, but it depends on us. It depends on us, because I don't even know how I'm here doing this expert neonatologist. 8 years ago, I was zero, when I was bonding zinc phosphate with Pascal Magne. So if we can do it, other dentists can do it, and it will start to become a necessity for the community. But the community don't feel that it is necessary because we made it so complex that people say, forget about it, they do. Very complicated, they are no aesthetic, and patient would have to pay more. And so this is, instead, when my patient come for the 3-step, they ask me, does it hurt? No, additive, let me try. Does it take a long time for the treatment? No, 3-step in 2 weeks with no anesthesia. Does it cost? No, because I even bond on an existing restoration. So you don't have to do a full mouth, just initial stabilization, a try-in, and after we do the upgrade. And you, with my monolithic, I know in front of you I cannot really say that, but I change material for the front. Monolithic, CAD-CAM, palatal veneer that goes with the front, and they call it tacos in the name of the Mexican food.
We love to see that in the marathon. You guys gonna love that technique.
Yes.
And so this is cheaper. You don't do a crown lengthening, you don't do endo, post and core, different set of provisional. You stabilize the patient and you send in the ward and say, okay, let's see if this initial is good enough for you.
And then we combine it. Okay, the last question is something more rational, but I'm gonna simplify it for you because we're not focused in X-rays at this point, so that you can tell us a position of the condyle. But with your background in prosthodontics, I would love to hear if you have any concerns about that. So the 11 questions say, can you describe the event that happened into the joint in reference with rotation and translation? And it's just to the fact to talk about the dogmas.
I agree with you, no hinge access. You have to know that I have an extremely low level of memory, in the sense that everything that they taught me, I forget about. If I don't see the pragmaticity, the practical aspect, I erase. So for me, they explain how the condyle should be. I say, forget about it. I need two different, I have adult people, the condyle are so different. What I want is the similar function. So I slow down the degradation, and these people live a better life. So I know that I cannot, and I don't like when people say so strict that they have to get an articulator, the condyle should be at the same level. No, I want that they, when they are function, they find the minimal energy level. The human being wants to work in minimal energy level. And so that means the muscle should be at peace. So this is all common sense. But I honestly, maybe call me in a few years, I have not gone outside my competence. That is the muscle of the lips, the tongue, and the muscle of mastication. Those are the ones that I always see. If you come out with the protocol, I will even record the posture and the turning of the head, because I'm sure in 4 years, I will go back and say, hey, you see how my patient has changed? Because my patient tells me that they sleep better at night, that they move the head, but I don't record. So I wish I could do that.
So that's what we're gonna do, and we work. You will see when I do my presentation the 7 steps of data collection.
And I
you
will
love
let
that.
you do 3 steps.
Oh.
So like
okay, well,
condense
make it 3.5. We'll go halfway.
Okay, the last part of that question, and that is really important because you're really into the teeth in the way that you made them touch after that you find what I call the sweet point, and everybody will find a different way. So now you find the relationship of the jaws, and then you building up a composite to create what I call adhesive additive occlusion, that I think is a beautiful word. And then how is that a scheme of the occlusion contacts? How are you trying when you build in, and now we have CAD-CAM, so it's a little more predictable to guide the proper relation. Is your favoritism to use like cos-fossa relationship, cos-interdental space? Are you trying to balance the long axis?
My problem, I tell you which are my problem. My problem that I have a population that is going more and more in class 2. So the relation between the first molar in class 2 is difficult for me to obtain what the milieu will talk about it. This beautiful harmony between the first mandibular molar that is guided and is mashed against the palatal cusp. So for me, if I have to say, my interesting is in the first molar, how Legal has schedule, and I love it, because with people, they have positioned that cusp in the right inclination, the right height of the cusp. When you ask them to chew, they tell you that they love it. It's comfortable, it's not time consuming. As soon as you verticalize, you lose the Wilson, the space not correct. It's very lock in the young occlusion that now we are giving to everybody, and the patients start to chop. These people if they had been better before, they will break everything and they are classified as a Braxer. And I don't agree with that, because we gave them shoes. They're really wrong for the way they function. So they need more comfortable shoes. So for me, the first molar, when I see functioning correctly with this beautiful palatal cusp, when the patient function, I can see when they cycle, I'm in love with that type of mastication. As soon as I see the vertical, I say, this patient is a risk factor for in his life for other things that break in the incisal edge.
Yeah, but go ahead. But in the planification of the case in the occlusal relationship, because at the beginning we kind of know the norms, and then the experience build that we prepare better for the next opportunity, next occasion, or the next planning of the case. Based on your experience about this setup and what you expect to the patient, what you're doing in advance to make the setup of the relationship of the teeth to avoid to have more interferences. I will tell you like how I describe what I do. I try to have vocal cusp in any fossa, because I need to have something that it fits, it gives stability for proprioception, but also I create 15 degrees of entrance and exit into the vocal cusp and into the lingual cusp. So the chewing cycles I'm taking as a consideration how they have entrance and exit. Like this is a standard for me, yes. And then actually when I was working with Milio and even with you guys noticed that in my orthotics is a little less interference, because I just count into that. So what you think in these cases, in your occlusion, are you trying to do anatomy that they a little more flat, or how is this relation in the depth in their cusp and the contact relationship? Of course, into the chewings you will monitor the function, but in that initial setup, what is your preference?
In the initial setup, I tell my lab technician to give me a important palatal cusp. So I don't want the flat, because otherwise I am obstaculate. I really want the mandible to smash on this cusp, if I can, because again, if it's class 2, this is not possible. I also ask my lab technician to give me, because I make a diagnosis, the people that I'm treating are the horizontal, ruminant. I want them to be a little bit more guided, but never by a steep canine. The canine is, like Emilio will say, is not considered in, out. My canine are always considered in the out motion. So you will see that canine actually is the intelligent person that say, hey, stop, you are going too out of the way, and rebring. But before the canine is this palatal cusp, because if you see the groove, this beautiful enamel groove, it just points in between the lateral and the canine. The problem here is that all the orthodontics are done in a standardized way where this molar does not have the right compensatory, because the distal vestibular cusp in the normal occlusion should be going down. Instead, they have a different torque. So already kids cannot chew. And so if they don't position correctly,
they bring them in, they take the curve of Wilson away, they make it very flat, and
that's why for me orthodontics is fundamental. That's why I want to go back to the development, because soon we will not see old people aging edge to edge, because everybody will be trapped in this wall and everybody will be claustrophobic, and we will not see kids. Kids are all class 2 more, because they don't breathe, they don't chew, and if they don't breathe, they cannot chew. And so if they don't chew, the tongue is in the wrong position, so it's a disaster. So yes, we are a population that will have less and less space, extraction of the premolar, but beautiful aligned teeth. So for me, I just want to say, I would be more, because people say, oh, you treat a population that break everything. No, I don't think this population are breaking in my office everything, because I give enough freedom that they do whatever, but is in harmony with their own mastication. But on the other hand, I am more scared of the kid that is sitting on the TV watching, on the couch watching TV 24 hours with the perfect shoes. I want my shoes, my restoration to live, because my kids is playing in the field. Function and motion is life. As soon as something is static, it lose. That's why women like me on the we need to move, because osteoporotic is there. So that's why nobody will tell you to stay and not to move.
So this is beautiful. Definitely, this is what happened when we have people fascinated, and actually we extend a little bit today because all the technical issues that we have. We apologize with the people. If it's part of the lecture, the conversation that was mute, we will repost the videos. We want to say thank you to Francesca for her open mind thinking, everything that he teaches. Actually, honestly, every time that I spend with her, I try to suck her brain, because honestly, sometimes simplicity is important. Without to be, you can be simple but not simplistic, and that's the key. Simple is try to make the process to go more efficient, but simplistic is to start paying attention on what is important, and it's something that is really happening in our profession. The motivation about this speaker is that it's a really truly story of life, somebody that is making everything better for the community. I feel myself a lot to learn. I want to encourage the dentists that they see in here, because I seen my two things that I want really to learn is have the capability to simplify things, because mostly we're coming now with a new transition in our lives, and I think we have the opportunity to create value for these physiological things into the patient, but still we need to have the capability to make it simple so we get the best of the two conditions. Also, to encourage the people to think open the box, and maybe we're going to have the opportunity to have more physiologic treatments for the patient. I think our commitment is with that 90% of the dentists that they don't consider physiology or function as really important part of the treatments. And then we can say just thank you so much, Francesca. We're looking forward for your lecture.
Thank you so much.
Thank
you
you,
were very
Alessio.
gracious.
Thank you, Javier.
Thank you for sharing all your invaluable experience with us. Thank you.
So we're ready for the next interview. It's gonna be at 1 p.m. We have all the technical issues, and again, I apologize, but the distance has been making things difficult. So we're gonna have at 1 p.m. Dr. Robert Walker, chiropractor, talking about a concept that he called craniodontics. If we believe that the skull is one piece, we're going to realize too much more. We're going to realize how the osteopaths and the chiropractors and how they have the capability to move the skull by itself, and how that is important, because sometimes can be some of that what is not allow the patients to go better. So I see you at one with a different perspective about how is the influence of the cranial release, cranial suture release, and cranial compressions into the human body. I see you one.
See you all then.
Thank you. I love you, Francesca. See you soon.
Love you too. Ciao.
Bye-bye.